Thank you. We are going to begin session 1,
글로벌 헬스케어 산업의
which is a global healthcare digital transformation. We are going to talk about the success strategy for that. We are going to invite 4 speakers, and we will talk about the issues or challenges that we are facing. Let me introduce the first topic. The Naver Healthcare Research Institute's Young-Hak will be making the first presentation. Good morning, ladies and gentlemen. My name is Young-Hak from Naver. Thank you so much for inviting me to this conference. We are having hybrid conference today. We are going to talk about the Naver healthcare and the healthcare in the perspective of our industry and Research Institute. Over the past 1 month, I've been to many different labs in the US and to see the revolutionary changes taking place at this moment. And I have been to the headquarters of the Therapeutics as well. So let me talk about the healthcare industry as a whole. First and foremost, shall we talk about the keyword? I believe that these are the keywords that we have to keep in mind for today's conference and for the healthcare of digital. First is the medical data integration and interoperability of that. And second is the life cycle healthcare or total healthcare. Another speaker will be talking about it later on. And the third is the digital medicine represented by the Therapeutics. This is a new kind of diagnostic tool or treatment tool. And the fourth is AI for doctor, which interests me most. I believe that healthcare apps and applications are quite important, but at the same time, we need to have more supply in healthcare professionals. As we witnessed during the COVID-19, we do not have, or we are kind of running short of the healthcare professionals such as doctors and nurses. So when I visited the US recently, I just saw some changes taking place there, how they can fill the gap of the shortage of the healthcare labor force. And also, I had a chance to share the perspective that other IT players had. So I'm going to share what I have learned with you today. First is interoperability of the medical data. As for the interoperability or compatibility of the medical data, it's quite a complicated issue, unlike what you might think. As for the app, you might have some financial apps, bank apps, or messenger apps. You may have sent money through that. You can send gift as well using the app. What about the healthcare services? We are able to utilize our healthcare services through the app too. And I believe that we have a roadmap for it too. And before I dive into that, I'm going to talk about the background. We have the medical law and medical act, which stipulates that all the medical information is owned by the patient. However, the patients do not own it because the medical chart or X-ray or all the images are stored in the computers, but not by the patient. So years ago, those data are stored in the medical organizations. So the medical law stipulates that they have to store all the medical information for 5 years. So the medical records and CD and related informations are stored in the medical centers. And they are storing all the medical information or data on behalf of the patient. But as we go digital, everything can be copied. In the past, we have copied using the paper for the medical record, but now we are having the digital or electronic record rather than the paper record, which means that you have access to the digital record. So let me have a look at what happened. Last year when I was with the Severance Hospital, let's say that the patients was able to get access to the blood lab results even before I have access to that. And he's asking that, well, how come my blood test results are so out of range? And he got that information, even I got the access to the information. In July, FURE Act, a federal law mandates that the information should be able to accessible to the patient. That's what the law says in the US. So all the medical centers in the USA, they are in a hurry to make sure that it will happen in line with the law. So the connectivity has become one of the hot topics. The data access and consultation with the medical health professionals has become the hot topics. In many areas, the US is leading, and I believe that healthcare industry is no exception. So what they are doing right now will be taking place in Korea. And we have to think about it in advance. And as you see on the slide, we have primary, secondary, and tertiary medical organizations and medical centers. And all the data, if they are interoperable, that will be good. But there are challenges to have them interoperable. And I'm going to share a case study of a country, which is Estonia, where the life cycle medical data are stored by the government. And you may say that they are able to do that because the country itself is very small. In the Scandinavian countries, they also have the medical record stored. They were able to do that because they had the single code of access for each patient. And this is what is taking place for the US Army based in Korea. They have one single chart for each soldier, so they are able to track that. And early this year, My Healthway was open in Korea, which means that all the medical record can be shared and you are able to download your medical information. And it contains 4 information. First, second, and 3, and third, and fourth. And one of them is the medical resources that you have utilized. And second is the prescriptions that you got. And the ones that you have paid for. And the third is the vaccines that you got. When you are young, you must have got the vaccination for the measles, so all that information is there. And the medical check-off information is stored, and you can download it. And the data are stored at the center, and it is named a My Data. It's like the financial My Data. It can be utilized in a constructive way. So we have different committees which are discussing how to utilize that information or data. And one of the challenges that we have is the certification. And we have Naver certification process. So you can go through the certification so that you can confirm your identity in order to make sure that only you, not other people, have access to that. So starting from the certification, we are trying to solve other problems or challenges one by one. Second is the life cycle healthcare. And as I said, you have prevention, prediction, and treatment, and post-treatment management. Everything should be combined or integrated and managed together. Whenever you go to hospital, you may think that once I leave hospital, the doctors are not interested in me anymore. That's not true. Even though you leave the hospital and out of touch, we are concerned about the health status of our patient all the time. And in 2021, we are able to track the status of our patients online, which is called the after treatment services. And we are having a lot of investment in this area. This is one of the examples, which is Omada. It helps the diabetic patients so that they can lose weight and manage diabetes. So 30 days, 6 days, and the 6 months, they can manage their health status. This shows that you have all the tools to manage your health status. During the Olympic, we have a famous player, volleyball player, Kim Young-kyung, who was an excellent leader to lead all the team members. And I believe that we need that kind of leader, and this software can be the leader for you to manage your health status. Since I joined Naver, I became healthier than before because I was able to download many different applications and take advantage of that. And every 2 weeks, I got all the consulting as I accumulate all the information about myself in the app. By doing or taking advantage of the app, I was able to lose 5 kilos. I had the chance to utilize the diet apps to lose weight, and I want to say that we have these kind of technologies or apps available. For the patient who suffer from the hypertension or other chronic diseases, it takes a lot of money to manage their conditions. Medicaid and Medicare are the insurance programs implemented in the USA, and a huge amount of expenditure is consumed by those people who are on the Medicare or Medicaid service or program. So how can you manage the cost or reduce the cost? By connecting all the information, I believe that we can take advantage of the data to reduce the medical cost. The third topic that I want to cover is the digital therapeutics, or smartphone wearables and AI apps that you can utilize. For example, in Singapore, Apple Watch is used to check the medical status of all the population in Singapore. That is a very big grand initiative launched by the Singaporean government, and we have a different data. And this morning, EKG can be checked by using the 2 fingers of yours, and that has been approved in the Korean market to be distributed. So in the diagnosis and treatment and in the medical service areas, I believe that many converged software products will be available into the market. In the KHIDI speech, the Therapeutics got the first digital therapeutics approved by the government in the USA. I had a chance to see him personally. In Japan, we have Align, our subsidiary, and they got married. Yahoo Japan or merged with Yahoo Japan. And one of the big investors is a SoftBank for Therapeutics. So I was able to contact him. And the conversation that I had with him was very interesting. Cognitive therapy is available in the digital therapeutics format. And for those people who suffer from insomnia, they are able to get the help from the software. which was very interesting. And one of the medical services that consumes a lot of money is this. Let's say that you reach 80, then your interest goes to your health status, not the conditions of your children or other things. So in order to remain healthy, you need to manage your health status starting from the time when you are young. And this application helps you to achieve that. In Naver, we have invited a professional specialist of the musculoskeletal system so that we can help our staff to remain healthy. We are in the IT industry, which means that almost all the staff have bad eyesight and they have a problem with the musculoskeletal system because they need to sit in front of the computer and spend long hours working there. So we decided to help our staff remain healthy or regain health earlier than later. We also have the junior service, another service for the children, especially for the children with ADHD. They develop a game to help them. As for those people who are obsessed with the gambling, one of the best treatment is to lead them to do fishing. And for those children who have ADHD, this kind of game may help because it can help them to concentrate. And we also want to provide this kind of services using our network. We have a phobia. Some people are afraid of making speech in front of a big audience, or there are other people who are afraid of taking airplane. Yesterday, Dr. O, in the famous program, they were sharing their personal stories and trying to provide some coaching or consulting services. And it was kind of a one-time consulting advice provided, whereas we are trying to provide the services on a long-term basis. So this is one of the wearable 3D glasses that can be worn by the patient to treat different kind of a phobia. And what is AI for doctor? Is it a recommendation service? No. How come we can ask questions about the symptoms of the patient and EMR and other readings, and all this can be combined for the sake of the doctor? And in Britain, they have utilized this kind of applications. During the opening ceremony of the Olympics, the British was introduced and the bed was moved around inside of hospitals. How come? It has been shown when Britain was introduced to the people, because Britain was the first country which introduced a nationwide medical service introduced. So they are very proud of having that kind of system. This means that general physicians are kind of government officials, which means that the patients need to wait long line in order to see their patient. So in order to fill the gap of the shortage of the professional resources of healthcare, they came up with this kind of application or app or chatbot. And by having some conversation with the chatbot, they are able to identify the professional doctors of which department they need to see. Nuance is acquired by Microsoft recently, and they are able to recognize the speech of the doctors. And I tried that system but the system was not able to recognize my voice because the system was not familiar to my voice. But once they get familiar to the owner's voice, they are able to document the speech. So if you see the video clip of the company, you can see that it will streamline the work of the doctors because the documentation can be done automatically without the doctors entering the information. The last case that I want to share is arteries. This helps the doctors to do the diagnosis. With the help of this kind of applications of software, I believe that the doctors and nurses can concentrate on the work that require a human-to-human interface. With this, I'd like to conclude my presentation, and thank you for listening. I believe that I can learn a lot from the other speakers, and thank you for inviting me.
Yes, thank you very much. That was first presentation in the session 1. Once again, thank you, Director Koon of Naver Healthcare Lab. So we will now move on to the second and third presentation of session 1. We will hear about a prime example of digital transformation in Korea and overseas. So first presentation is on digital transformation cases and insight of Korea domestic healthcare. So in Korea domestic healthcare, we will learn about the cases of digital transformation and the indication of those cases. We will now listen to founder and CEO Choi of Huraypositive. Yes, good morning. I am Choi from Huray. Thank you very much for the invitation. Director Ra talked about examples and cases from the US. I will now cover how digital healthcare is progressing in Korea. So Huray focuses on management of chronic diseases. Omada was an example cited by Director Ra in the previous presentation, and we do something similar to what Omada does in Korea. It has been 12 years since I founded the company, and first 8 years are very different from the recent 3-4 years, so it's a far cry. When I first founded the company, the term digital health didn't even exist in Korea, and nowadays everyone knows what digital health means. Digital health became a household term. And as I would continue in the presentation, I will talk about how digital health is reaping convergence with different industries like financial industry and insurance industry. It hasn't only been 2 or 3 years since those results come to fruition. In the US, digital healthcare progressed really fast, but in Korea, speed started to pick up only a few years ago. So this is brief introduction of myself. I am Choi, founded Huraypositive. And let's now turn to why digital healthcare and how it is contributing. So this map has x-axis of value creation through digital healthcare and y-axis of digital maturity. So when you look at the x-axis, high value creation from digital but low digital maturity, so lower right-hand corner holds big potential for future business. And the red circles indicate the areas that are being highlighted as a convergence area between digital health, insurance, pharmaceutical, and healthcare. So digital healthcare in a nutshell is digital transformation, digital technology used in convergence with a different healthcare delivery. So digital technology being applied to the entire spectrum of healthcare is digital health. So United Health Group's CEO said digital health will soon be synonymous with health. So in fact, many examples were presented by Director Ra just now. When you look at those cases, digital healthcare come to complete convergence with healthcare, so there will be no boundary. When you think of financial services, you can see what it means. So making wiring money, remittance, taking out loan, paying interest. In the past, you had to go to bank branches, but nowadays everything can be done digitally. So likewise, digital healthcare will be synonymous with healthcare, and this change is taking place faster than you expect. So when you map out digital health, this is potential outcome you can get. So in the broad scope of healthcare, you have smaller area of digital healthcare and traditional healthcare in the oval shape on the right-hand side, where digital technology is not fully utilized. And telemedicine and teleconsultation is very important element for digital healthcare. So the U.S. digital healthcare market grew very fast. There are multiple reasons. When you spend 1 million won in medical expenses, Medicare, Medicaid support is about 44 to 45 won. So, but in Korea, when you spend 100 won, the government reimburses 63 won out of that. So insurance is really strong in Korea. In prevention, in management, you cannot really actively reimburse because the burden on the fiscal condition. Nonetheless, because the society is aging really rapidly, and we are coming to an inflection point in terms of chronic disease and many other lifestyle diseases. We need to have digital health to reduce the cost and expenses and increase care. So that has become a policy direction. So out of prevention, diagnosis, and treatment and management, prevention and management can welcome new stakeholders, including financial actors, financial institutions, to provide new digital services to the population to enhance health for everyone. So that is a recent digital healthcare direction taken in Korea, and that is one of the motivations why digital health become even more active recently in Korea. So let me give you some examples. You will be able to understand in a more detailed way how digital health is flourishing in Korea. So first, convergence with financial services. So insurance companies are taking keen interest in digital healthcare. They're becoming very active participants. There are multiple reasons, of course. Financial services is all about using current and present resources and money to hedge the risk of future. So from the insurance company's perspective, there are two main risks. One being taking premium to provide fees in the future, and usually they run and manage the asset to have gain from those assets. But nowadays the financial market is not conducive to that. The interest rate is really low and return on investment is low usually. Second, in the past, people's had insurance policy as just natural part of the culture. But new generation population, they're not as eager to buy insurance. So because of these two risks, they were thinking about the future of the industry as a whole. So the insurance companies, managers, and top managements are concerned about that. So with deregulation on the government part, the financial services started to take in many suggestions for convergence, and insurance companies are looking for new business, and they also try to return their earnings or return their gains back to the society. That's why they're taking more interest in healthcare to improve customer value. They need to manage their costs and expenses. They have to manage their asset. So because of many of these issues, financial services industry, mainly insurance companies, became a key stakeholder in healthcare, digital health. So for example, KB reduce your premium when policyholder works more. So if you take good care of your health, with special policy on number of steps, you can offer lower premium for life insurance and car license. Because people who walk drive less and they drive safely. So it has become part of a very effective marketing tool. And this data also is used for health management. They can also be enriched to reach a new value, create new revenue source. Likewise, Samsung Fire Insurance also offer NFC, the walking mileage, so they can buy Gifticon or they can get a discount on their premium depending on the steps number. So many different services are being offered, and it covers almost 1 million, 2 million policyholders. So digital healthcare permeated to our everyday lives, knowingly, unknowingly, very naturally. And let me show you some models that shows convergence with medical services. This is mobile doctor service called My Baby Has a Fever. If you have a baby, you will know when their fever spikes up at midnight. Parents can be at a loss what to do. What medicine should I give? How often do I need to give the medicine? So when you see a pediatrician or GP, doctors have protocol in their brains to treat high fever. So they follow the protocol to give a prescription. But the front-end protocol, whether or not to go see a doctor, that is what this application covers. So should I take my baby to emergency room when the temperature is very high during the nighttime? So fever-related data can be accumulated and share the data with your attending physician, your attending pediatrician. Although it is not linked to electronic medical record, but there are still ways to link day-to-day medical data with what you can get from your doctor. There are only 650 download on Android. When you add Apple Store download, it's over 1 million. And the rating is 4.4 out of 5. And so it is really well received by a lot of parents. Digital health services such as this are very well utilized. Only a few years ago, many people were skeptical who would use digital health apps or digital health, but that was not a reality. When these applications satisfy a met need, you can really create a practical value out of these digital health apps. So in Korea, telemedicine started to be offered. In COVID-19 pandemic, temporarily telemedicine became legal. So in the past it was legal. So without COVID-19, telemedicine itself has some illegal element in it. It is not allowed legally. So because of that, a doctor here used U.S. medical doctors of Korean origin, so Korean American doctors. So doctor here covers teleconsultation and delivery of prescription drugs. Of course, there are some differences of opinion, association of nurses and doctors, but still these new novel services are being attempted at, and this can lead to an entirely new type of industry. So we are at the starting point of an emergence of new industry, new services. So I believe these two are very interesting examples from Korea. And next is convergence with pharmaceuticals. In the keynote speech, Therapeutics CEO talked to us. So digital therapeutics are being offered, and digital treatment also being offered in Korea in mass. Particularly cognitive behavioral treatment is the main topic. So insomnia or compulsory activity or addiction. So CBT, digital therapeutics are quite flourishing. And many startups also focus on respiratory rehabilitation, and they applied for approval processes at FDA. And UNABs, using VR, narrowed vision area after experiencing stroke. So they're also going through item approval. So maybe later this year or earlier next year, we'll be able to see first digital therapeutics in Korea. And Hira also thinks these new digital therapeutics can improve overall health for the Korean population, and it can also drive down fees given to the medical services, reducing the burden on the medical health insurance resources. So I think the progress will accelerate in Korea as well. So there's new services that are prescribed along with medicine can be another example. So it enhances compliance of patients with drug medication, and there are other very active convergence activity or services offered in conjunction with pharmaceutical industry. The very important first step of good healthcare is measuring or monitoring. So how can we enable very optimal monitoring? So data collection and analysis is also all about digital. So device is the first gate where digital data can be collected. So Humano is a Korean startup that offers watch form factor ECG machine. And this is a ring format that takes pulse and different vital signs. So these are already marketed and available. When you have this ring on, you can receive vital information on your app, and this can be sent to your doctor. So this is different starting points in the form of medical devices for new convergence. So this has been my presentation. Although the US is leading this change, but still the speed of following up with and catching up with changes in Korea is enormously fast, and I've shown you some examples from Korea. In 2-3 years of time, I think unimaginable scale and scope of digital health will come to reality in Korea. Thank you for your attention.
네, 고맙습니다. 휴레이파지티브
Yes, thank you. That was CEO Choi of Huraypositive. He talked about how digital technology is using conjunction with healthcare. Now we will learn from overseas examples, and those will be presented by Professor Paul Harris of Medical Information and Biomedical Engineering Department of Vanderbilt University, and he will be presenting online. The topic is digital transformation and strategy to support clinical and translational research.
Hi, my name is Paul Harris. I'm from Vanderbilt University in Nashville, Tennessee. I'm excited about being here with you today and honored to be part of the symposium. I want to talk today about classes of informatics-based software platforms and service lines to support the research enterprise. I want to spend a little time then talking about one specific class of research tooling called electronic data capture and management software. And then finally, I want to end with an overview of the All of Us program here in the US and some of our work in the Data and Research Center. First, I want to take a Vanderbilt-centric approach and talk a little bit about how we've attacked the problem of optimizing the use of clinical data for research. This is a fairly busy slide. It's from a paper that we published in 2014 talking about just this. Again, it's a little bit busy, so I'll break it down into really simple terms or simple concepts. First, recognizing that clinical data come from multiple systems and multiple sources. Our first objective was to be thoughtful and mindful about going to those data sources and getting data in. Once we have those data pipelines laid to our clinical systems, the next step is organizing it. At Vanderbilt, as we organized it, as we built data warehousing tools, architecture to support rapid aggregation and repurposing, we decided that we would create two sets of the data. One is identified for purposes where we need, our research teams need identified data, but also there are a lot of purposes that can be addressed using de-identified data. So we have tooling in that data pipeline to de-identify the data as it comes into another source. We call the de-identified source here the synthetic derivative, and the identified the research derivative. So getting it in, aggregating it, and organizing it is great. It's a useful and necessary step. But unless you go to the next step and make it useful for end users, for the research community, and at Vanderbilt, we mean a diverse community of researchers across medical domains. Unless we can make it useful to them, it's just a technical exercise. So we spend a lot of time building tools and service lines to support the research enterprise, make sure we're meeting them where they are with what they need. In terms of repurposing these data for hypothesis generation as well as operational research. This is a little bit of an old slide, so the numbers are a little bit dated, but the concepts are still spot on and accurate. In the top right, you see some of that making it useful self-service tools that allow people to go in and create cohorts from our multi-million patient data warehouse. Be able to sort of create cohorts and look at data and even retrieve data again in that de-identified way for research purposes or identified in purposes like participant recruitment. Recognizing that not all research use cases can be met with self-service tools. We also have data programmers that understand that data and for fee-for-service can support ad hoc queries, honest broker operations, and what have you to support individual research projects. And again, that's that pyramid down in the bottom middle of the page. So at Vanderbilt, we build all of this infrastructure as part of an organization called VICTOR, Vanderbilt Institute for Clinical and Translational Research. We build services, we build tools, we build service lines but we also evaluate them. And so this is a screen that shows the number of publications that were attributed to where researchers gave attribution to certain tools that we create and disseminate over the last decade. And you can see the ones that I've got in red here, circled in red, those are the ones that are directly related to that body of work that we were just mentioning. So in that body of work and in supporting the research enterprise, you can see from the numbers and the publication attributions that they're very relevant. And they are indeed supporting a diverse academic research enterprise. This is not the only service line that we have. We actually have a pretty good history over the last 15 years of thinking locally. You know, what do we need in terms of informatics tools and services to support specific research use cases like data accessibility, like recruitment tools, and so forth. Whenever possible, we like to disseminate those out to others. I've got a good example of that in a platform called Redcap, which we'll talk about next. Redcap started as a thought exercise. We knew we had a lot of researchers out there in the community that were doing lots and lots of diverse research. One common element is they all needed a place to support data capture and management, and we needed to, as an institution, to provide them with a way to do that in a simple way without a lot of cost or burden. So we did a needs assessment, looked at use cases around study databases, registries, assessments, research operations, registries, you know, what have you. And found that just about everything that we do includes some level of prospective data collection and management. And so we created a tool called Redcap that stands for Research Electronic Data Capture. Tooling at first was very simple, being able to come up with ways to help research teams define case report forms or patient-reported outcome surveys to support data capture. Do that in a way that's very meaningful and easy for the end users. And you see here a case report form with hopefully easy to use, easy to understand instructions and methods to get data in. Here we also built in a full set of audit trails so that we knew who was doing what to the data at all times. That helps with security, that helps with audits and all kinds of things. And so we wanted to make sure that that was baked in from the beginning. We also recognize that we have many thousands of projects at Vanderbilt, and so we wanted to make sure that we were mindful of the fact that we needed certain users to see certain databases, but not all. And so spent a lot of time on rights administration, and then finally we spent quite a bit of time on getting the data out. So data capture, data management is one thing. But at the end of the study or trial, we know that people want to get it into statistics packages. And so we built tools to do that, as well as de-identifying it on the way out, if that is useful. That started in 2004. About 15 years later now, we've got 95,000 projects that date back to 2004. And you can see from the self-described purposes of these databases in the middle, that they're used for all types of research along the continuum of basic to community type research projects. This is a screenshot of a typical week. In fact, it's this week. See that in any time of the day, people are usually in our Redcap system at Vanderbilt, and during peak hours of weekdays, we usually have somewhere in the neighborhood of 2,000 to 3,000 people in at any given time. So it's very robust, and again, it's supporting many researchers and many research projects. Going back to that same principle of measuring impact of what we're delivering, this is the line that shows the Redcap publication attribution over time. Somewhere around 2006, we realized that other institutions outside of Vanderbilt also needed these types of tools. So we created a model where we would give the software away to other institutions. They would then support their own research community. We would sort of learn from what they were learning from a broad array of researchers. We would listen to that input And that's how we would develop the next iteration of what features and functions would go into the platform. Again, we do that, we did, and we do that now at no cost to institutions that are academic, nonprofit, or government organizations that want to work with us in this consortium. The consortium has grown quite large over that time. Last count, we have 5,418 institutions from 142 countries. And again, it's available at no cost to academic, nonprofit, and government organizations. The really great thing about having all of those sites and institutions partnering with us is they bring about 2 million users over time, of course. But again, thinking about evolving platforms, used systems get better, principles, we've had a lot of great input from a lot of great partners over the years to make this product better. Including some great partners in South Korea, and you can see the names of those on the right as well as the locations on the left. In terms of measuring the impact of this platform for global research, not just the research that we're doing at Vanderbilt that I mentioned earlier, one easy way to do that is to go to bibliometric sources like Web of Science. This is a screenshot of a paper that we published in 2009. I think, and a lot of people cite this in their methods section for research projects. So using bibliometric analysis, we can see the types of categories of the research that they're publishing on is very, very diverse, as you can see here. And if we look at current or recent hot papers or highly cited papers in respective fields, that are using Redcap, you can see, from the titles and some of the topics here that some very, very important and timely papers are being published using Redcap. Of course, over the last 18 months, a lot of those have included tie-ins to COVID-19. Okay, so finally, I want to talk a little bit about the All of Us program in the Data and Research Center. This is really cool. It's a national effort. It was initiated by President Barack Obama. And this is a picture of him presenting this information in an address from 2015. It's really a beautiful program. The basic tenet is we'd like to recruit 1 million patients, 1 million participants or more into a longitudinal study where they consent and give their electronic health records, they give their biosamples for DNA and genomic assessment. They provide surveys and participate in the program actively. And then we give that, we use that resource to provide access for researchers in a way that promotes rapid discovery and research use cases. So this has been going on for some time. Participants at a glance from this month show that we have 411,000 participants who have donated, 253,000 of those have donated electronic health records, and you can see some of the other numbers there. Do want to show the map on the right showing that these participants come from all 50 states. And there's a real focus in the program on making sure that we're representative of racial and ethnic minorities and other individuals that are from underrepresented communities in biomedical research. So that's a really, really big deal and a big difference for this particular program. Our work at Vanderbilt with partners at Verily, Columbia University, and the Broad Institute, our work is in a space called the Data and Research Center. And again, going back to those principles that we mentioned just a moment ago, one big body of work that is right there in our focal area is getting the data in, organizing it, and then making it useful for the research community. It's a very big program with a lot of partners from a lot of different institutions. So this is a fairly busy slide again, but I wanted to bring that up because in our role as the Data and Research Center, we spend a lot of time working on that, pulling data in from various partners about participants, as well as the data that are generated with that participant data and on behalf of that participant population. So we spent a lot of time on getting the data in. We also spent a lot of time on organizing it. So starting from the left, there's a lot of data sources, as we mentioned. We spend a lot of time doing data harmonization, refinement of those data, creating a curated data repository that is fit for use for the research community, as well as documentation about those data that need to be there to be able to sort of rely and use the information. Then the third one, perhaps most important, is making it useful for researchers. We take a little different approach than tradition here. Traditional approaches to this sort of a program would be to get the data in, make cuts of that data, and then deliver those data sets to researchers for them to use locally for research. We flipped the tables here, and using cloud computing, we're basically building the data into a cloud computing environment, building tools into that cloud computing environment, and then bringing the researchers to the data. This is really cool because it allows us to standardize things, and it also democratizes access. Not all researchers have the tools locally to go and do big computational programs like are needed on this data set. So we like it from several different angles, including the democratization of access. The DRC, the Data and Research Center, publishes this information in a public website. And you can go to that public website anytime you'd like. It's called researchallofus.org. Some of the tools that we have on that public website are a data browser. Let me dig in and see if I can search for diabetes or any type of concept and see what the All of Us program has in terms of that type of data, either from surveys or EHR or what have you. We also publish a lot of data snapshots to make sure that we're being forthright and open about the data assets that we have from that very important community of volunteers. We have a Researcher Workbench. This one requires, it's available at no cost. It's institutions, so researchers at institutions that have sort of signed agreements. But with that access, bringing those researchers to the data, we have a platform called the Researcher Workbench, as you can see here. That Workbench has the concept and notion of workspaces, being able to do a data set builder, a cohort builder, notebooks, and other concepts. But basically, the gist of it is we build a user-friendly environment in a cloud computing environment that is there to support individual research projects. Once a researcher is in as a registered tier user, they have the ability to go in and very rapidly build new projects and build new workspaces and add collaborators as they will to support scientific discovery and exploration. Here's a screenshot. Again, all of this is available on that public page that I mentioned a few moments ago. But part of what we do is we collect information from our research users on what types of projects that they're doing with that data asset. That's available, and you see here there's 673 at this moment. You can see the details on any of those 673 if you want to go to that public site. Here's a few spotlights. Some great new work that's just come out around COVID and the pandemic. You can see that previously we've highlighted research in sexual and gender minority populations, as well as, again, underrepresented communities like the one that you see in the bottom right. Publications, we have those available on the website, and again, just researchallofus.org. As time goes along, we'll be adding to the publications that are citing use of the platform, and we anticipate, based on everything we're seeing that we'll see a very rapid growth of those publications over time. So I want to stop here in the all of us description with a picture of our team. It's a fairly large team, as you can see from one of our most recent face-to-face meetings. I also want to thank the teams from the Vanderbilt Institute and Vanderbilt Institute of Clinical and Translational Research that I mentioned earlier, Office of Research Informatics at Vanderbilt, the Redcap Consortium partners, and again, last but not least, the All of Us program with the DRC, the National Institutes of Health, and many, many partners in that initiative. And then finally, I want to thank you again for the invitation to present today, and hope that there are opportunities to collaborate with individuals in the symposium going forward. Thank you.
네, 고맙습니다.
Yes, thank you very much. That was Professor Paul Harris from Vanderbilt University of the US. We learned about digital transformation and strategy needed to further support clinical and translational research. So the next presentation is fourth and final presentation of session 1. We will learn from university's case as well. After the fourth presentation, here in this room, we will invite different experts to conduct panel discussion. During the panel discussion, we will try to entertain questions posted in the YouTube channel on the chat that you have posted. So please stay until the panel discussion. So we will now welcome the final speaker of the first session, Manager Harald Mylod, of Digital Health Industry Manager from Germany Trade and Invest. He will talk about trends in digital healthcare industry.
Welcome, ladies and gentlemen, to the Seoul International Conference in 2021. My name is Harald Mylod, and I'm Manager Digital Health at Germany Trade and Invest. Thanks for having me in the session, Success Strategy of Healthcare Digital Transformation. I will present you trends in the digital health industry from a European perspective, and here especially about the German experience. Due to our time frame, I can't get into all details of the German healthcare market. Here are some figures which indicate that Germany is amongst the biggest healthcare markets in Europe. And an interesting figure is that we have 82 million health insured people. 73 million have a public health insurance. 9 million have a privately insured. That will be interesting for later on for the digital health case. Also, a quite impressive number is the total healthcare expenditure. It's 391 billion euro for Germany. To sum it up, Germany is a very attractive and big healthcare market in Europe. Nevertheless, I would like to show you some trends which form the background for the digital health case. Do you know that Germany is one of the oldest populations worldwide? 22% of the population is at least 65 years old. Only Japan has a higher percentage in this respect. This demographic change is also reflected in the growing number of care recipients in Germany. It is expected that by 2030, about 5 million people in Germany will be in need of care. So aging society, care dependency, and chronic diseases are important market drivers, which will inevitably result in a higher degree of healthcare digitalization. Therefore, it is not very surprising that the estimates for the market volumes of digital health in Europe and Germany are high. Between 2020 and 2025, the European digital market is estimated to rise by 50%, up to a volume of 232 billion euro. The German market will have a 25% market share with 57 billion euro volume. In the last 4 years, the Federal Ministry of Health has adopted an amazing number of healthcare acts which accelerated the development of digital health quite considerably. The rule breaker was undeniable the Digital Healthcare Act, which came into force in January 2020. It represented a systemic opening of the market for digital health applications for 82 million insured people, 73 of them, as I already pointed out, in the statutory health insurance and 9 million privately insured. So that's a big market. Together, the adopted healthcare acts facilitated the progress of different parts of the digital health system. First, the access to an electronic health record for every insured person is a centerpiece for the gradual connection of all stakeholders, may it be patients, physicians, hospitals, insurance, therapists, etc., within the German health system, which has formerly been insufficiently in exchange. Under certain conditions, teleconsultation, telemonitoring, and other telemedical procedures are allowed and reimbursable. The access and use of patient data includes the possibility to gain insights which could potentially result in new approaches in precision medicine, prevention, epidemiology, and pharmaceutical ingredients. The potential for that is enormous, but so there are the data security hurdles which have to be considered. Much attention has been raised by the opportunity to apply for the DiGA directory. DiGA stands for Digital Health Applications, which would enable, for example, medical apps to be prescribed by doctors. So the slogan "app on recipe" made the rounds. So what is the definition of a DiGA? What is a DiGA? DiGA is accepted if it is a medical process class 1 or 2A under the medical device regulations. Its main functions has to rely on digital technologies, and its intended use has to be centered around the patient with possibly inclusion of medical doctors. The product functionalities have been detection, monitoring, treatment, palliation, abatement of pain, compensation of diseases, injuries, and disability. So how does the fast-track process work, the fast-track process into the DiGA directory? The procedures is as follows. The developer of the DiGA submits an applications. The BaFaM, the Federal Institute for Drugs and Medical Devices, which can be compared to the FDA in America, proves 3 months the requirements and the positive care effects. So the requirements are concerning safety, quality, functionality, privacy, data security, and the positive care effects have to be the medical benefit, the structural and procedural improvements. If the BaFaM approves the application, then the DiGA is directly going to the listing in the DiGA directory, or it disapproves the application, but with the opportunity to get a preliminary listing in the DiGA directory, which gives the applicant the chance to justify the disapproved requirements or care effects within a testing phase of 12 months. After that a decision is taken and the DiGA is approved or rejected. If it is disapproved, you got into the DiGA directory, and if it is rejected, well, then you have to kind of think about your development again. If you are in the DiGA directory, you get reimbursement by the health insurance, which is quite attractive. Afterwards, price negotiations, so how much can you charge for your DIGA is going on, but that is a different process and system which would lead too far at this point. Now we have like nearly 1 year of DIGA applications. It is time to look at how many applications have been submitted. It's a total of 89 DIGA applications have been submitted. 5 have been continuously improved, so directly, and 15 have been preliminarily approved. And you can already see that only a low percentage of the application is directly going through. Usually you need to kind of strengthen, improve the DIGA so that it can get approval. 4 have been rejected, 42 have been withdrawn. You have to imagine that this isn't kind of iterative communication process between the BioPharm and the applicant. So at some point, people get the insight, okay, we still have to work on our DIGA, and then they withdraw the application. And 23 are under evaluation, which reflects that it's an ongoing process. So every month, a new DIGA is adopted, and others are going to the preliminary approval, whatever. So this is an ongoing process, and new applications are handed in every month as well. I was asked to say something about the semantic approaches of the DIGA applications. The finding is that 26 are in the field of cognitive behavioral therapy that can be subsumed under the headline mental health. And 7 are for movement therapy, and 6 are aftercare. And the biggest group is others with different topics like knowledge transfer, diary functions, monitoring, motivation, gamification, and training. So you can see that there are loads of different thematic approaches on DIGA. So that's it. Let me say a few words about our organization. Germany Trade and Invest is the economic development agency of the Federal Republic of Germany. Our shareholder is the Federal Ministry of Economics. We have 2 locations in Germany, Berlin and Bonn, and we have over 50 locations worldwide. We are represented on all continents with local employees to help German and foreign companies with their expansion plans. And our free information, online and print, for foreign companies includes market and industry analysis, in my case, for healthcare. We provide information on all financial aspects of establishing a foreign business in Germany, so financing, state support, etc. And we have information on all legal and tax aspects of establishing a foreign business in Germany. Of course, partnering and site selection is part of our consultation. So thank you very much for your attention. Here you can see our contact details, my contact details. Feel free to contact us and ask questions. Thank you very much. Goodbye.
네, 고맙습니다.
Yes, thank you very much. That was Manager Harold Mylord of Germany Trade and Invest. He talked about trends in digital health industry, a European and German perspective. Thank you very much for the presentation. So we are done with 4 presentations. In this first session, we will now continue with the panel discussion. For successful adoption of digital technology for healthcare and digital transformation, we need to take into account different elements. So to talk about this, we will invite 3 different panelists. I would like to ask panelists to come forward and take a seat.
제1 세션 패널 토론의
So
가장은
the moderator for the panel discussion will be Professor Young-Hak Kim of Ulsan College of Medicine, University of Ulsan College of Medicine, Asan Medical Center. We will now invite Director Koon from Naver and CEO Choi of Huraypositive. We will start the panel discussion.
진행해 주시겠습니다.
Thank you. My name is Kim Young-Hak. We have 4 speakers in total in session 1 on digital healthcare and transformation, how it can be applied to Korea, and we have learned the cases in overseas countries. And as for the time gap, we got the video recording from the overseas speakers. So we have asked a question to Dr. Harris, first and foremost. For the All of Us program, it's a big-scale data, and securing such a data is of greatest importance. That's what I understand as well. But in order to capture the data, we need to encourage individuals and organizations to participate. So from the organizer's point of view, how do you encourage people to engage? And do you have any incentives provided to them? So this is a question to Dr. Paul Harris.
Specifically, I want to talk about that within the context of the All of Us program. This ability to be inclusive and recruit and retain and engage a diverse participant population representing all backgrounds and geographical areas across the United States really is needed to ensure that the research results are both inclusive and meaningful to all populations. This has been really a huge focus of the program from the very beginning. I think the question, how do you encourage participant engagement? You do it intentionally, you do it with purpose, and you do it from the very beginning. So from the very beginning of All of Us, a lot of community engagement activities, listening exercises, even before the protocol was defined, to make sure that the participants had a voice in this very important study for which they were partnering. Participant representatives are invited to serve on the executive committee as well as the steering committee. They really are considered key individuals in terms of architecting and running the program, and their voice is incredibly powerful. Offering incentives to individuals and organizations. Individuals who sign up for the program and go through the initiation process of donating samples and in-person visits are compensated with financial incentive. But also there's a lot more than just financial incentives in being a part of the research program that it's All of Us. There's return of value and return of results and those things that really are designed with the participant in mind to provide value back to them, in addition to monetary incentive. Organizations who participate, they are chosen. Some are chosen for their ability, their relationships to serve minority populations and to encourage those populations to participate fully in research and the program.
Thank you very much for your answer to the question. We have about 15 minutes to have discussion sessions. So Dr. Na and Dr. Choi will be in the discussion session. And listening to the presentations, I realized that in the industry, the digital health will continue to expand and evolve. That's what I saw in your presentation. And when it comes to the digital healthcare, I believe that the doctors are involved and I'm part of it. So I'm going to ask this question from the healthcare professional's perspective. This question is to Dr. Choi.
So you talked about how industry is leading digital health. So there is a perspective of individuals and the perspective of health systems or hospitals or medical centers taking part in that. So the key question is, what's in it for the individuals and hospitals? You cited two examples that is in the broader scope of healthcare, but it is not a far cry from the everyday app that we use. So how is it expanded and how is it applied going forward? So what's your projection for that?
지금 이제 디지털 헬스의 바람이 되게 거센
So
상황인데요.
the change of digital health is really vibrant. The convergence with healthcare service is very prominent. And one thing to think about is in startup world, we have term product market fit. So it talks about how the product can be presented to the market in a best suitable way. I took an example of my baby has a fever. There are hundreds and thousands of parents who are using the app, and they voice their needs. Can I have access to healthcare professionals on the app? Temporarily, it is legal, but in the past it was illegal, so that service was not created. But we can explore new needs and unmet needs in the market. So from a healthcare consumer's perspective, there are clearly needs that are not satisfied with existing services. So we do clearly see the values that new digital health can create. But then, from the perspective of providers or healthcare workers, what are the benefits? What are practical benefits they can get? They cannot just only operate on the mission of betterment of the entire humanity or bettering health for everyone. So the healthcare professionals, as a provider of healthcare service, we need to think about how we can structure at the government and the national level the service give and take, let's say, for healthcare professionals. That would be the platform for better services and even more mutually beneficial services. Now, to come back to the example of my baby has a fever, maybe if it can lead to telemedicine, it will benefit consumers, and consumers are willing to pay. So in those cases, the healthcare professional, when they take part in the app and provide a teleconsultation, taking the risk, they can get bigger compensation. So, for example, bigger fees or compensation for unreimbursable medical service. Only then these services can be sustainable.
Thank you very much. I believe that we agree that we need it, but there are some concerns and challenges as well. And in that context, can I ask this question to you, Dr. Na? I believe that as for LINE, I believe that they have done some businesses in the Japanese market, but so I believe that you have some use cases. But in the Korean market, what kind of strategies are you adopting? Can you share your opinion on that? As for the Korean industry or Korean health, we adopt a K-Bio or K-industry, which means that we are one of the best practices that other countries want to share. But as for our services, the fee for service is the concept that we are based in. What I mean is this. Let's say that you go to hospitals a lot and get the prescriptions in many cases, and you have to get this kind of activities taking place in order to get the compensation from the doctor's point of view or the hospital's point of view. I just told that I went to the US, and even on the same system, they are able to collect the data, which means that we are getting very creative models introduced. Even though in the same scheme, HMO, the payers or the other player or the health organizations can be separated so that if they reduce the cost, they can get the compensation as well. So we will continue to evolve. And in Japan, the remote health or telemedicine has been legalized, but it has not been actively used. That's what concerns the management offline. But let me tell you the reason why. Because the gatekeepers, the healthcare professionals, when they have better compensation, the market will be more vitalized. As of now, it's not the situation. It's not. So compared to face-to-face medical services provided, they do not get enough compensation for the remote or telemedicine service. For the volleyball, we have a coach and playing coach, and we have other players as well. And in the healthcare industry, I believe that the players got diversified as well. In the German's case, 10% of the GNP is involved in the healthcare industry, or 10% of the population is a healthcare industry. And if it applies to Seoul, 10% means like 1 million people involved in the healthcare industry. So we can come up with many different models, and this Hub Bio can be a very good starting point. Based on the new technology, we can come up with the new models, and we can explore them. And within the legal framework, we can launch many different projects as well, including the one launched by Dr. Choi, or Representative Choi. And let me ask you one more question. We got a question from the audience about the digital medicine. It has not been widespread as of today, so it's quite confusing from the individual's point of view. For the digital health application service, do we need to get prescription from doctor every time that I have the symptoms? Or what about if I have a side effect? For the mental diseases and cognitive impairment diseases, we can utilize them. But for the digital medicine, what do you think? It's kind of vague or confusing as of today. But what about the regulations? What will be the regulations that will be applied to? It will be reimbursed too? Very good point. Talked about two important points. One of them is safety, and the other is compensation. As for the safety, there was something which is revolutionary. Corona mRNA vaccines, the phase 1 and phase 2 were done without the 3. And it has been used in the big population. In the past, we have a clinical phase 3 we need to go through, but in the emergency case, we have taken the fast track, omitting one of the steps. So it has widened our point of view to the medicine and vaccines. But as for the new medicines, many of them are very expensive. And FDA and Korean counterparts, they cannot omit the approval process. However, we can be creative in some areas, which means that we can give or allow some very special price for that. And once the new product is approved, it's very expensive because they have spent a lot of money during the clinical trial process. So we can come up with a different model to compensate the new drug in a different way. However, we cannot sacrifice the safety of the patient and the people. But when it comes to the cost, I believe we can be creative. And the corona vaccine have shown us a new way, a new possibility. And let me add just one comment. You have heard of clinical trials these days, and in the past, we have done clinical trials this way. We come to or approach big hospitals, and the big hospitals recruit patients and get consent. But in the US, they get the consent, but the drugs are distributed from the clinics in the communities. And then the drugs are distributed through the digital module, which means that we can cut down on the administration cost. So even when it comes to the clinical trials, we can utilize different models. And if you are very effective in adopting the new models in Seoul, I believe that we can come up with creative, effective, and different models too. And a lot of pilot projects can be implemented as well.
So last question to Mr. Choi. We're here for Seoul Biomedical Conference, of course. And ultimately, in healthcare, online and offline will converge. And still, the actor of community is still important, even in the digital world. And as someone who offered and managed a healthcare service, community-based healthcare and digital health, how can they come together? Of course, Seoul is a vast city to call a community, but still, what do you think? There are many ideas. Of course, digital healthcare service should be used by end users. Creating it is not the end. So we have to identify who needs and wants those digital health service. So parents with toddlers have high needs, for example. We do not have currently a really good example of digital health that can cater to those parents. If that kind of service can be launched smoothly in the community of Seoul, it will be very beneficial to residents. Currently, low birth rate is quite low, but post-term and post-birth management and care is not doing optimally in many communities. So if digital care for those mothers, and newborn babies, that can be a great candidate for high efficacy, high effectiveness digital healthcare services for different communities. So to sum it up again, we have to identify target customers or users with greatest needs, and if we can tailor digital health for those audience, it can play an important role in enhancing quality of life and health for Seoul residents. Yes, thank you very much. We ran out of time, so we will wrap up the panel discussion here. Once again, I would like to thank the two speakers for their presentation and panel discussion. And again, I offer my congratulations on the conference and thank you again.
네, 고맙습니다.